Welcome, everybody. Welcome to another MS Views and News program. You know, this is so early in the year, and yet this is now already our 5th program of the year, and I think they've all been in February so far, so I'm glad that February is a short month because March is going to pick up, and we're going to go forward into April, May, June, where we're going to have 11 programs to do in just 3 months' time. So anyway, my name is Stuart Schlossman. This is an MS Views and News program. I want to thank you all for coming, and thank you. And listen, who we really want to thank tonight, we want to thank those that gave us the grants, the sponsorships, and that would be Sanofi-Genzyme, and that would also be Biogen and Mallinckrodt, and they gave us needed sponsorships for us to be able to hold this program for you. And why do they want to give it to us? Because they want you to really learn. Our programs are not about the medications, and they know that. They want you to learn about MS. They want you to learn about the other aspects about multiple sclerosis. And they want you to learn from the programs that we provide. And we do 50-plus programs a year right now in 23 states. Thank you. All right. So anyway, I wanted to thank those that are here tonight. I also want to thank Dr. Kantor. And Dr. Kantor, I just want to read something to you. Dr. Kantor is the past president of the Florida Society of Neurology, past director of the MS Center at University of Florida, Jacksonville, and the Neurology Residency Program Director at Florida Atlantic University. He's a proud member of MS Views and News Medical Advisory Board, and he's also, that he doesn't put down, he's a face that a lot of people know when they see the MS World videos. He's the guy that's up there going, around the world with MS. So let's welcome Dr. Daniel Kantor. Good one.
Well, hi everyone. How are you guys doing? Good. What we're going to talk about today is we're going to talk about multiple sclerosis. But we're going to talk about ways that we can make the MS more about you. For those of you who have known me and have known me for the past a little bit over a decade, I've been in Florida now for 12 years, we really want to take this and say, how do we make MS not just about the textbooks and not just about the MRIs and not just about the science, but how do we make MS about each and every one of you? And that's the idea of these balanced series of talks with MS Views and News. The idea is how we can make you the most successful. If you look at this drawing and this image, many of you have seen this. This is an image of a person who was ice skating, and she fell, and she was weak for 3 months, and then she got better. Then she lost vision in one eye, and then 6 months later that got better. Because bad things happened followed by good things, the Catholic Church decided that she was a saint, and they named her Saint Lenina, the patron saint of ice skating. We like to think of her in multiple sclerosis as the first person in recorded Western history to have had multiple sclerosis. She had bad things that happened, followed by good things that happened. She had relapses, followed by remissions. The relapse really is the hallmark of what is multiple sclerosis. Not everyone with multiple sclerosis has relapses and remissions, but for most people who do, they have a very characteristic way of this happening, pretty similar to what happened with Saint Lenina. In 1903, Sir William Osler said that the best teaching is that done by the patient himself. It was 1903, so we'll forgive the latent chauvinism. He didn't say herself or themself. But that idea that the best teaching is that done by the patient himself or herself really teaches us how important it is when we're thinking about medical issues. It's very easy to get tied up in the science and the p-values and the statistical significance and forget about the person in front of you. Not the patient in front of you, not the case in front of you, but the person in front of you. And I think it's always important for us to remind ourselves in the healthcare field that we're dealing with actual people, with full emotions, with full lives outside of what happens inside the doctor's office. And that's why we came up with this idea of MSTAR, or the Multiple Sclerosis Team Approach Rule. It's a fairly easy idea to understand. The basic idea is that the person with MS is really at the center of that team. On the one side, you have the doctors, the nurses, the physical therapists, all the people who are involved in your healthcare needs. On the other side, you have the more important people, your friends, your community. And here in the South, community often means religious community as well. Your significant other, your family and friends. But your job can also be affected by MS, either with this idea of retaining your job with reasonable accommodations, or when it is time to ask for disability, to use the American with Disabilities Act to actually have disability. And then there's the MS community. The MS community overall is a rich community of nonprofits, large and small, some regional, some national, some local, with the idea that there's support groups where people get together either in person, there's events such as this one, then there are people who get online into support groups. And recently we were able to publish on this data on what happens when people with multiple sclerosis use the internet and social media. How does that help not just them individually, but how can that help their doctors as well give even better care? Everyone's needs are different in multiple sclerosis. Everybody with MS has a little bit of a different story. Some people that might have to do more with memory. Other people might have to do more with language. Other people might have to do more with movement. Other people with sensation. Other people with pain. Other people with fatigue. And everyone's needs are so different, and that's why it's important when you're thinking about MS, not just to think in generalities. I know that often when we talk about MS, we talk in generalities. But when you're there in the office visit with your individual doctor or nurse practitioner or physician assistant, it's time for you to talk about what's happening with you specifically. And that means that you have to build your team, not somebody else's team. You have to build your team. And that means that what you have to do is you have to tailor it to your needs. That means that you have to have open lines of communication, not just between you and each team member, but you have to have among the team members as well. You have to make sure there's actually communication. And just like any sports team, you have to be ready to make trades when the time comes. So if somebody on your team is not pulling their weight, is not being a good team member, is not supporting your MS diagnosis, then it may be the time for you to actually make a trade. So when we're thinking about communication, there's one ugly, frowny face, red signal that looks a little bit like a Pac-Man that should be off on the side, and that is jargon. The word jargon is a fancy word that means fancy words. There's no space for jargon, not coming from us as your doctors and not coming from you. So I think it's pretty simple to understand where a doctor may use jargon. A doctor may use fancy words. Sometimes we use that because we don't know what we're talking about. And so we may want to use more confusing words because then it confuses everything. Instead of just taking the language and breaking it down into easy to understand language for everybody to understand. But I also think it's not good for you to use jargon. And what do I mean by that? I've seen many people walk into the office and they say, I have neuropathy. And I think what they're trying to do is be helpful. They're trying to give me a name for something that they're feeling. And maybe what they're trying to describe is pain or less sensation. But what they're actually doing is delaying their care. Because the word neuropathy means neur, like nerve, pathy, like pathological. When a neurologist hears the term neuropathy, we immediately think peripheral neuropathy. MS affects the central nervous system, not the peripheral nervous system. So now you've told me you have something aside from MS, which maybe was not your intention. But now I hear peripheral neuropathy, and as a neurologist, I think diabetes, diabetes, diabetes. Meanwhile, you don't even have diabetes. So now we've spent all this time talking about a diagnosis that you don't even have. Instead, if you had said to me, well, I'm feeling pain, or I'm feeling less sensation, or I'm feeling burning, then I could have better understood what it is that you're feeling. So remember that communication really is a two-way street, and it's not just us who has to not use fancy words. We ask that you, as the people who are coming to see us, don't use those fancy words either. When we think of MS, we think of it as a lifetime autoimmune diagnosis. Now, I use the word think. The reason I'm using the word think is because I think it's arrogant for us now in 2018 to think we fully understand MS. We think it's autoimmune. Maybe one day we'll find out it's not. But our best understanding of multiple sclerosis right now is that it's autoimmune, meaning your body's defense forces, instead of just attacking outside invaders like bacteria, viruses, fungi, and even cancers, attacks yourself. When it attacks your joints, we call that rheumatoid arthritis. When it attacks your skin, we call that psoriasis. When it attacks your brain and spinal cord and optic nerves and the covering of those nerves, we call that multiple sclerosis. I like to think of it as lifetime, not lifelong. That makes life sound long and arduous. Not chronic, but lifetime. Sort of like the cable station. You turn off the TV, the cable station's still going on in the background. So even when you don't focus on your MS, it's still going on in the background. And even when you're not watching TV, you still have to pay your cable bills. Same thing with MS. Even when it's not affecting you, you still have to go and take care of it. So you still have to be on the disease-modifying therapies to try to slow down relapses as well as progression of disability. We think of MS as affecting the central nervous system. We think of it affecting the spinal cord more commonly, then the optic nerves, and then the brainstem. There's both demyelination, so loss of myelin, as well as loss of the axons, the actual wires themselves. And we think that MS happens in somebody who has some sort of genetic predisposition. So there's not one MS gene that's yes or no, but there's some sort of something in your genetic background that makes you more susceptible to MS. And then there's some sort of environmental trigger. And those together are what causes people to actually have MS. So if we fully understood either the environment or the genetics, we'd be traveling to Scandinavia to win a Nobel Prize. But what we understand right now is that in people with the right genetic background, there's some sort of environmental triggers. I don't think it's just one trigger. So I don't think it's as simple as something like Epstein-Barr virus. Epstein-Barr virus or mononucleosis virus, the kissing disease, 80% of the regular population has it, has had a history of it. 100% of people with MS have had a history of it. But then we don't see 80% of our population with multiple sclerosis. So maybe it's Epstein-Barr virus and something else. We're learning more about other sorts of environmental triggers. For example, out of University of Southern California, they looked at people who lived closer to the highway. People who lived closer to the highway, a marker of environmental pollution, had more MS than people who lived further away. So that doesn't say that car pollution causes MS, but that says that if you look at a population overall, when you're exposed to pollution, you're a little bit more likely than if you hadn't been exposed to pollution. So are these factors acting together and causing multiple sclerosis? And that's what we're still trying very hard to understand. When we look at MS, we can look in the microscope. We don't generally do that because we're dealing with people. And when there's people, people are living and we use things like MRIs to look at what's going on. But if we looked at a microscope, we would see the nerve fiber, the axon itself, as well as that myelin that wraps around it. So what we think happen is that activated T and B cells, they cross the blood-brain barrier, they launch an attack on the nervous system, and this causes problems with nerve signaling. And that's what we think basically happens in multiple sclerosis. This slide is for the quiz afterwards, where I'm going to ask you to name each of those acronyms. But this slide is constantly changing. Our understanding of how T cells and how B cells interact and cause multiple sclerosis is changing. And it's changing because what we understand from MS comes from understanding a little bit from looking at slides of people who have passed away with MS. Actually, in Netherlands, they actually have a brain bank where they get people's brains right after they pass away. So it's still fresh, as opposed to looking later where you can't see the inflammatory markers. And they're able to understand a little bit better about what's actually happening in multiple sclerosis. But for a lot of what we understand about MS has to do with our animal models. And our animal models of MS are imperfect because we do something to make those animals have something that looks like MS. So we're not really giving them MS, and so we can't fully understand it with just the animal models alone. When we think about how to understand MS, we also use our naming as a technique to understand it. And what do I mean by that? Well, it used to be just several years ago we talked about 4 subtypes of MS. Now we talk about 3 subtypes. The people who had that 4th subtype don't suddenly not have MS. It's just we've changed the language. So we've changed the way we discuss MS. And that's going to happen every several years. Committees come together, and by committee, we have differences in naming. That doesn't change who you are as a person. It doesn't change what you're going through. We think by far the more common type of MS is called relapsing remitting MS. Then some people go on to develop what we call secondary progressive MS, where you may start out with those relapses, but then you may still have relapses or may not, but you also have a progression of disability. And then 15% of people say, what do you mean getting better and getting worse? From the beginning, I've just been getting worse. And we call that primary progressive MS. Oftentimes, your doctors will be interested in what happens during the relapse, during the attack, the time that you're calling the office. But I think for many people, the time that becomes even more important is what happens even in between attacks. What are the day-to-day symptoms that are happening? What are the day-to-day issues that you're facing, not just the dramatic things that make you call the doctor? Are you having spasticity or muscle tightness? Are you having pain? Are you having problems with your thinking? So when we think about treating MS, we can think about it in terms of the triple threat. And I want to thank our MSketeers for allowing me to use a name. But the three MSketeers, when you think about the treatment of MS, really are the disease-modifying agents, symptomatic treatment, and acute exacerbation treatment or relapse treatment. So what do we mean by this? Well, on the one side, we have the disease-modifying agents. Now, disease-modifying agents, the idea is not to treat a day-to-day symptom. The idea of a disease-modifying agent is to be a proactive medicine to change the future of your multiple sclerosis. It's a preventive therapy. And when we look at the FDA-approved disease-modifying agents for MS, in 1992, we had 0. Now, in 2018, we have 13 separate branded products. We have 2 unbranded generics and 1 branded generic. We've come an amazing leap forward in just a little bit over 2 decades. And we've been able to do this not because the doctors are smarter, not because MS is easier to treat than other diagnoses. We've been able to do this because of people with MS who have volunteered to be part of clinical trials. And by being part of clinical trials, we're able to better understand MS and we're able to better treat multiple sclerosis. Another way of looking at that list of medicines is to look in terms of the intersecting spheres. If you look at it in terms of self-injectables, in terms of IV or intravenous medicines, and in terms of oral medications as well. There are many ways of splitting up, and as we get more medicines, these graphs are going to become more and more crowded. Every year we see 1 to 2 new medicines, so every year these spheres have to become smaller as we include more medicines. That's a good thing. There's no medicine that's right for everyone. And as we have more options, it means that there's more options that may be beneficial to you. And that's what you should be spending some of your time talking to your doctor about. What is the right medicine? Not for everybody. Not the right medicine for that person, but the right medicine for you. And that's what you should be discussing. To try to figure out how you can disease modify. Another way of looking at this is in terms of just over time what's happened. And as you can see, there's a lot of green there. Most medicines that we get to what we call phase 3, which is the later trials, the bigger trials that show whether a medicine works or not, most of the medicines that get to that point actually get approved for multiple sclerosis. We have some medicines that fell off the map, and other medicines that fell off but are coming back on the map. And then we have a large pipeline of other medicines that we're still trying to develop as well. These are proactive medicines. The goal of these MS disease-modifying therapies is to try to prevent relapses and prevent progression of physical disability. I compare it sometimes to people who are taking an aspirin to prevent stroke. What are you trying to do? You're trying to prevent the problems that happen from the stroke, you're trying to prevent the disability that happens from the stroke, and you're trying to prevent death that happens from stroke. And that's why you're taking something like an aspirin to try to prevent it. That is exactly what you're doing here with these disease-modifying therapies. When you take antihypertensives, so medicines to affect your blood pressure, your doctor isn't trying to give it to you just to bring down an artificial number. They're trying to get your number down so that you won't have heart attacks and strokes. Same thing here with MS. We're not just trying to check off a list and see whether you're on a disease-modifying agent. We're actually trying to prevent both relapses as well as progression of physical disability. Unfortunately, no diet has been proven to do this. And that's not for a lack of trying. There are studies looking at different diets. In fact, the best study was looking at something called the vegan McDougall diet. Vegan means no animal products, and McDougall means no fun. So the vegan McDougall diet is a low-fat version of the vegan diet. It was so hard they had to send the patients from Oregon to Santa Rosa, California to learn how to do the diet. At the end of the year, there was no effect on MS relapses, no effect on disability, no effect on MRI. But there was a 20-pound weight loss, there was a reduction in blood pressure, a reduction in cholesterol, and very interestingly, a reduction in MS-related fatigue as well. Which makes you think, before we think about fancy medicines to try to help things like fatigue, we should think about what we can do in terms of modifying our diet, what we can do in terms of modifying our exercise in order to do that as well. No supplements or vitamins have been proven to do this, to be this proactive medication yet. And so there's a lot of research going in. Many of you may have heard of vitamin D. How many people are on vitamin D? Almost everyone raises their hand. How many people are cured of MS? And everyone's hands go down. And that shows us vitamin D may be important in MS, but it may be a little bit too little too late. It may have been important when you're early on in your MS and even in utero, so when you're in your mother's uterus, but later on it may be a little bit too late to try to reverse something that happened so many years ago. And that's helped us in understanding. So for example, many of us make recommendations now. If a woman with MS is pregnant, we recommend that she supplements with vitamin D. And we recommend that she supplement with vitamin D, and we recommend that the baby supplement with vitamin D. Different people have different levels. We haven't yet come up with a consistent number of what those recommendations are, but the idea of what can we do early on is something that we're always looking at. And we're always thinking, what can we do to try to change MS and make MS of the future better than MS of today? And that wouldn't have been possible without people who volunteer for clinical trials. Stem cells. There's a lot of news about stem cells, and people will read stuff on the internet, and some news is fake news and some news is real news. And we have to be a little bit cautious. When you think about countries where you wouldn't drink their water, you have to think about whether you would go to that country in order to get something that they're calling stem cells when there's no oversight and you don't actually know if what they're giving you is really there. We are finally doing real stem cell research. Most studies, however, are focusing on relapsing multiple sclerosis, although oftentimes what I find are the people who are asking more about stem cells are people with either very active relapsing MS, where it may be appropriate, or people with very progressive multiple sclerosis, where unfortunately it may not be as appropriate at the time. It's unclear if hematopoietic stem cells, hematopoietic means there are stem cells that have to do with the blood. A stem cell is basically a cell that can become other types of cells. But when you take cells that are blood cell types of stem cells, well, they could become immune cells, but they're not going to become new nerve cells. And so people are looking at stem cells and thinking, oh, I'm giving myself new nerves. That's not always the case. Oftentimes what you're doing is just modifying the immune system. Neuronal stem cells may be more interesting, but there's less research that's going on. And there's even a proposed secondary progressive MS trial that's starting out in New York, but they're drilling holes into people's head and placing those oligodendrocyte progenitor cells. Oligodendrocytes are the cells that make myelin, so the cells that are going to make those, they're putting them surgically into the brain. But what happens to the spinal cord? And we say that spinal cord is the most common part that's affected by multiple sclerosis. So there still is a lot of research that needs to be done. We don't fully understand how MS disease-modifying therapies work. We have an idea on some of them, but sometimes we have an idea and then we find out that maybe that idea isn't fully right. But we can classify them in some ways as immunomodulation, where you're changing the immune system. We may have medicines that keep your immune cells, those cells that are going to attack you, away from your central nervous system. So either on the other side of the blood-brain barrier or inside your lymph organs. We may have immunosuppressants where we actually push down those white blood cells. And by pushing them down, as they raise back up, that may actually create a new immune system. And that new immune system may be friendlier to you than your original one that you had as well. What do we know about the efficacy, about the strength of these medicines? Well, many of the medicines have been compared to placebo, so to nothing. And that means it's very hard to compare among those trials. Few of those medicines have been compared to one of the interferons called interferon beta 1a intramuscular or Avonex. And then we also have 2 of them that have been compared against Rebif, so interferon beta 1a subcutaneous or under the skin. And that means that we don't have enough head-to-head comparisons among our medicines, but as you talk to your doctor, we do have basic understandings of where medicines fall into place. The problem is that we're always weighing the risk of your MS versus the risk of the medications themselves. And the benefit that we may see with a medicine that may be earlier, that may be safer, but may also not be as effective. And so those are things that you and your doctor are always talking about, and you're always considering where you are in terms of the spectrum of taking risk. So for example, some people right here up in Jacksonville will go skydiving, and other people would never go skydiving. Some people will go gamble at a casino, and some people would never go to a casino. So all of us are different in terms of our abilities to take on risk, and that's true when it comes to our choices of disease-modifying therapies. Now, I said that there's 3 threats in the 3 musketeers. So there's disease-modifying agents, there's symptomatic treatment, and there's acute exacerbation treatment or relapse treatment. Now, a relapse is also called a flare, attack, or exacerbation. We changed the word from exacerbation to relapses because neurologists were exasperated by people with MS calling them exasperations. But when we think about these, and it doesn't matter what you call them, we're talking about the same thing. And what we're talking about is this idea that you have a new or worsening neurological symptoms that are coming from the central nervous system and that are preceded by a period where you're basically not being active. So you're basically doing the same, and then things start to happen. They don't necessarily happen suddenly. It usually takes days to weeks to months to happen, but sometimes it can happen suddenly, and it can be more confusing, and it can look like a stroke as well. We want to make sure that you haven't had a similar problem in the last 30 days, because then we would call it all part of one relapse. Some of these definitions just have to do with the language that we have to use for clinical trials. As you can imagine, if we're trying to study MS, we have to make sure that we're using common language as well. And so it will be confusing for you sometimes to know if what you're having is a day-to-day symptom or if what you're having is an MS relapse. And sometimes it will even be confusing to your neurologist as well. And so when somebody has a relapse, we want to make sure that they're not having something called a pseudo-relapse. A pseudo-relapse means a fake relapse. It doesn't mean you're faking. What it means is that if you raise your core body temperature through outside heat, through stress, through fever, those things, what they're going to do is bring out your older symptoms and make it feel like you're having those same problems again. But it's not actually a new relapse. If we treat that problem, we treat the fever, we treat the overheating, then your symptoms go away. And that tells us that that wasn't actually a relapse that was happening. So when you go to the world's most favorite doctor, Dr. Google, and you type in almost anything, you're going to find multiple sclerosis. And so an MS relapse could really be almost anything that you can imagine. Now, there are some that are more typical or more classical than others. So if somebody has problems with vision in one eye, we call that optic neuritis. If someone's having problems where they're having either sensory problems or weakness, and it's coming from the spinal cord, we call that transverse myelitis. Some of them are going to be more classical, but other people are going to have periods where they have more depression or more fatigue, and it lasts for 3 months and then gets better. That might be an MS relapse that you're actually describing, and that's where it's important for you to work with your team and to work with your neurologist to figure out what is going on with you, not what's going on in general about MS, not what you're going to find with Google in general, but what's going on with you specifically. So when we think about acute exacerbation treatment, There's two ways of treating treatments that are FDA approved, and then there's other ways that we think about that are not FDA approved. So the two ways that are FDA approved are to use corticosteroids, to use steroids, and most commonly that means IV Solumedrol or IV methylprednisolone. Usually 1,000 milligrams, usually daily for 3 to 5 days with or without oral steroids afterwards. And then there's another medicine. It's either given into the muscle or under the skin subcutaneously. It's called HP Acthar Gel or ACTH, which is also used to treat MS relapses. Sometimes we do off-label things where we use something called IVIG or intravenous immunoglobulin. We're giving you a blood product where we're trying to bring down the MS relapse itself. Or we even clean out the blood with something called plasmapheresis. What's important to know about MS treatment of relapses is that if we're treating the relapse too much, that tells me that that first arm, that first MS cateter is the wrong one for you. So we shouldn't need to be treating too many MS relapses because the idea of the disease-modifying therapy is to prevent them in the first place. I also said that the third of the MS categories is symptomatic treatment. So when we think about symptomatic treatment or symptomatic management, I didn't say symptomatic pharmaceuticals or symptomatic medications. In fact, much of what we do does not involve medications at all. It involves breathing exercises, mindful meditation, visual imagery, yoga, tai chi, and yes, we do sometimes use medicines, but most of the time those medicines are not even FDA approved for what we're using them for. So if you've ever been on anything for MS and pain, that's not approved for MS and pain. If you've been on anything for MS and fatigue, that's not FDA approved for MS and fatigue. If you've been on anything for MS and cognition and thinking, that's not FDA approved for MS and cognition. We do have some medicines that are approved for individual symptoms of MS, but generally that's not the case. So when we're thinking about the symptoms, we're thinking about what to do in between the attacks. We're not talking about the relapses or the attacks. We're talking about how do we treat the day-to-day symptoms that you're having. And those symptoms can be varied. For everyone, they're going to be different. Most commonly, MS starts with the spinal cord, and so tingling or weakness are going to be common symptoms. Muscle tightness that comes from that is going to be a symptom that people may have. People may have pain. People may have fatigue. People may have vertigo. There can be lots of different symptoms of multiple sclerosis, and we're going to have to think based on that individual symptom for you as an individual how we're going to treat it. So if there's so many symptoms and everyone's so different, how do we start to think about it? And the way I like to do that is to categorize things. And the way I like to categorize it is to think about visible symptoms, invisible symptoms, and private symptoms. So what do I mean by that? If you're not walking right, you don't need to be a neurologist to say, oh, that person's just not walking right. That's a visible symptom of multiple sclerosis. If you have pain, I can't see that pain. You feel it, but I can't see it. That's an invisible symptom. If you have problems with your bowel or bladder or sexual dysfunction, I can't see that as an outside person. Across the street, I wouldn't know about that. But it's definitely not invisible to your care partner. To the person you're in bed with, that's very visible. And so that's more of a private symptom. I think it's useful to categorize symptoms this way because when you're going in to talk to your neurologist, it helps you in that checklist of what you want to talk to them about and also recognizing what you need to tell them more about. People sometimes think that we can see their pain. They think it's obvious to us as their doctor. We could see their walking difficulty perhaps, but we can't see their pain. And so realizing what kind of symptom you have and whether it's visible or not visible or whether it's private, is going to help you in discussing things with your neurologist. For example, the private symptoms are ones that people do not volunteer to us. They may volunteer the invisible symptoms, but the private symptoms are just that, they're private. And people sometimes were a little hesitant of talking to their neurologist about it, especially when you consider that 75% of neurologists are still over the age of 55 and almost predominantly men. And what that means is that if you have a population of people who are, a lot of them are women, predominantly women, they may not feel comfortable talking about things like bladder function or sexual function. And that means that when we're walking out of the room and our hand is on the doorknob and we're about to walk out and you say, "Doc, one more thing." And that one more thing is the most important thing and it's the most private thing. Don't wait till the end. Don't shortchange yourself in your office visit. You get less time with your doctors now than you did 20 years ago, 10 years ago, 5 years ago. So take that time and think about it before and categorize what you want to talk about so that you can have the best office visit for you. The symptoms of multiple sclerosis can be almost anything. And that means that those symptoms are going to be different for you. And it's not going to be obvious to your neurologist from your MRI or from anything else what you're feeling. And you have to make sure that we understand. And that's why we use a multimodal approach. We don't just use medications. We use communication. We use education about certain symptoms. We may use physical and occupational therapy. We may use other types of therapy as well. What we need to happen is for you to make the office visit, not just an office visit, but to make it your office visit. And the way to do that is to get prepared. Just like any meeting you would go to with a professional you would be prepared for this. Make a list of your questions. Don't just walk in the room and say, "Oh, how are things going?" "Oh, they're going fine." Once you've said that, the doctor's already thinking about the next patient in the waiting room. Make sure they understand what are the important topics. In fact, I so much think so that I think that you should actually bring up your questions first before your doctor gets to their questions. Your doctor will always get to the questions that they have. They may have questions because the insurance wants to know, because the government wants to know, because they want to know, because they ask everybody with MS, or because they wrote down to ask you next time you come. They're going to get to their questions. Start the office visit by talking about your questions first. Get through your checklist before they get through theirs. Don't have the office visit tied up in mundane things. And what do I mean by that? The list of your medications is something that we don't need to be thinking about so hard. Just make that list at home. Have that list, bring it to the office. The medical assistant can scan it in beforehand. The doctor has it right there in front of them. You're not spending time trying to remember which medicine you're on or when you take it. Do that beforehand. You do not need to be spending the time that you could be spending talking about your care, talking about that. Bring your actual MRI CDs with you. Many of your neurologists are going to want to actually see your MRI itself. They're not going to want to rely on somebody else's report. They're going to want to actually see it themselves. Tell the office your specialty in retail pharmacy so they know where to send prescriptions to. Many prescriptions nowadays are electronic. And when we do electronic prescriptions, we need to select the exact pharmacy you're going to. We need to know which of that retail pharmacy chain, which place you're actually going to, so that we can send in the prescription to the right place. So make sure that you have that. Know your prior authorization anniversary date. Many of you who have had MS for a while know that all of your medicines, all the disease-modifying therapies, are going to need some sort of specialty pharmacy, and there's going to be some sort of prior authorization usually. And those prior authorizations are different than the prescription. So those are going to run out at a different time than your prescription runs out for the year. If you know that date, then you can call your doctor's office and make a visit in that month before it's going to run out, so that you can time your office visit so that the doctor knows what to answer when they're asked all these new questions for your prior authorization. Know your date as much as possible. You want to have your pharmacy send in a refill request. They can send those in electronically, and we can answer them electronically as well. And you want to make sure when you call the office to make sure that your labs and other necessary tests are there before you even show up for the office visit, so that we're not spending the time when we could be spending with you looking for mundane things like tests. Know your date. Know your prior authorization date. May not be what you wanted to sign up for, but MS isn't what you wanted to sign up for. As physicians, we didn't want to sign up for knowing about prior authorizations and insurance companies, but that's the reality that we live in. And so know your date. And then what we can do is, by taking this idea of MSTAR, or the multiple sclerosis team approach rule, when we have these individual MSTARs, they can work together. And by working together, and I don't know a better example of that probably than Stuart Schlossman. This idea of a person with MS helping other people with MS and lending a hand to each other is how what we're doing is forming the multiple sclerosis patient network. With this idea of each individual MSTAR being able to help each other, it's the only way we're going to move forward. And this happened not so long ago. You know, in the hurricane, we had people who were on social media telling us there was somebody in Tallahassee that needed help. Well, some people went to their house and helped them. We had somebody right here outside of Orlando who's in a wheelchair who needed to put things into his attic. People came to his home and helped put it to the attic. We had people with MS helping other people with multiple sclerosis. It's times of tragedies, and we're facing those tragedies right now down in Parkland, but those times of tragedies are where we see people really rise to the occasion, where we see people go and help each other, and we see people lending a hand one to another in order to make a better life for all of us. And that's how we form the multiple sclerosis patient network. The good news is that there's more MS research than ever. In the 1950s, there'd be a little bit of research. Now you open up our major journal for neurology, and 75% of it is about MS. That research is just climbing and climbing and climbing. And that means that together, we can truly make the multiple sclerosis team approach rule turn into the multiple sclerosis team approach reality. I'd like to thank you so much for your attention, and I'd be more than happy to take any questions that you might have.
So the toughest portion of not saying thank you to Dr. Kantor is, who's going to go first in a question? Thank you, Rich.
Just a question about the MRI. Many times over a period of a year, you're getting progressively worse, but the MRI does not reflect that. It actually shows sometimes the opposite in the MRI. So just wanted your thoughts on that.
The question was about MRI. So MRI or magnetic resonance imaging. Sometimes, even though clinically, so you feel like you're getting worse, and your doctors may say you're getting worse as well, your body seems to be getting worse, your nerves don't seem to be working as well, but your MRI doesn't look like it's changing or doesn't look like it's getting worse. It may even be looking like it's getting better. So why do we see that disconnect? There's a well-known disconnect between how someone's actually doing and their MRI. MRIs are imperfect. It's the best test we have to look inside and to kind of look inside through a person's body and look at their brain and spinal cord, but it doesn't always reflect what's going on. And part of that is because they're just pictures. So some of it has to do with technology. Some of it has to do with where our technology is. Our technology is dependent on the magnetic strength, or the Tesla. So the T that you see after that. So the stronger or the higher Tesla or higher T's mean you're going to see things that we wouldn't have seen otherwise. And it means that when we do our regular MRI, we're missing vast portions of the nervous system we're not able to see because our technology and our imaging characteristics and our way that we process images just aren't good enough yet. Other parts of it have to do with the fact that actually when we look and we see these big lesions, we're only seeing big lesions. Besides that, there's small things going on. There's this low-lying inflammation, this low-lying attack that's going on, and it's not seen that well by standard MRI techniques. And what that means is that you may be having things going on, but we're just not seeing them because our technology just isn't able to do that.
Hi, Dr. Kantor. About a medication, I can't pronounce these weird names. Ocrelizumab, you know the name. Okay, some of the side effects have to do with if you have a previous infection. In my case, from Puerto Rico, we used to get vaccinated by tuberculosis or something like that, and then it keeps showing positive. Is that something that with that medication can be, go ahead and try it or just stop?
So the question was about a medicine called ocrelizumab or Ocrevus. It's the latest of the FDA-approved medicines. It's a medicine that's taken IV, it's taken once and then 2 weeks later, and then from then on, just one time every 6 months. The idea of ocrelizumab is it's a monoclonal antibody when you see MAB at the end. And monoclonal antibody means mono, one. Clonal means they're all the same, and antibody is one thing that sticks to another. Well, ocrelizumab sticks to the B cells. It's a type of the immune cell, and it pushes them down. So it kills those B cells. And it keeps them down for a while, and that's why you can take the medicine every 6 months instead of having to take it several times a week like some of our other medications. The question was, in those kinds of medicines, you're affecting B cells. And B cells, we know, are important in fighting off infection. So you want to make sure you don't have an infection going on, and you may be tested beforehand to make sure that you don't have various types of infection, including the infection called tuberculosis or TB. In the United States, people are not vaccinated for tuberculosis. Outside the United States, in much of the world, people are. They're given something called a BCG vaccine. And that happens, and people actually still have a scar from when they were a little baby and they had that scar. And what that means is that our standard test to look to see if you've been exposed to tuberculosis is called a PPD, so it's a skin prick test, and they check you again 3 days later. Well, that shows a positive if you've been exposed to BCG before. So it used to be the way that people who've had a BCG would have to get tested would have also have to then get a chest x-ray to make sure there's no tuberculosis. There is now a blood test called quantiferon gold, and that blood test can be used even on people who have had a BCG vaccine in the past. And that will tell us whether you have been exposed to tuberculosis or not. So now there's a blood test to help you beforehand to know whether you've been exposed to tuberculosis or not.
Question?
Oh, okay. Hi, Dr. Kantor. Lots of people are concerned about some of these drugs and then coming down with cancer. Because over the years, I think some of them had been used for cancer purposes, but some of them are really starting to be more afraid, I don't want to take that drug because. So can you, I know there's not a question, but can you explain?
Sure. The question was about the risk of cancer from the disease-modifying therapies. So let me tell you what we're talking about here. The disease-modifying therapies affect your immune system. Your immune system is not just important in fighting off viruses, bacteria, and fungi. It's also important in fighting cancers. Cancers are abnormal cells of yourself that start to grow and multiply and then can spread and cause problems. Well, your body can recognize that and can try to push down, and normally all the time we have cells that are almost cancer-like and our body's cleaning it up. But if you affect someone's immune system by giving some of these powerful medicines, have you affected their ability to fight off cancer as well? And so we know that it's true for some of our medicines right now that are FDA approved for MS, that there may be a slightly greater increased risk of cancer from the medicines themselves. And so that's why the FDA has that information in the prescribing information or the package insert. What everyone needs to do with their doctor is weigh a risk of something that might happen versus the MS that's right there in their face. And say, well, how much is my risk of MS versus my theoretical risk that maybe I'm affecting myself and could be making myself more likely to develop a cancer? And then are there things I can do to mitigate it or to reduce my risk? Are there things I can do to check and to examine and to make sure that I'm not going to develop cancer?
I have a question to ask you that is often asked of us on social media. There are a lot of people that are newly diagnosed, of course, every single day. And what do the physicians, what does a clinician like yourself tell people now they're newly diagnosed and where they stand in, what medications are available? That's the first part of this question. Second part of this question is there are a lot of people in this room probably that feel that they do not need medications anymore. And how does the medical community address that issue as well?
The first question had to do with this idea of what do you do with someone who's newly diagnosed? So someone who is new to the diagnosis of MS doesn't have a history of what they've been on, and they may have less of a history of how their MS is doing. It used to be people had to wait 13 years to get diagnosed, so you knew what their MS was doing because you could look back over the past 13 years. Now people are often getting diagnosed in that first year of symptoms, or very, very shortly after having their first symptoms. So what do we do about that? Well, when we look at our clinical trials, these people actually match even better than the rest of the population They actually match better who we studied in our clinical trials. In our clinical trials, we often would need people who have had at least one attack in the last year or 2 attacks in the last 2 years. And on many of the trials, people may not have been on medicines before. So in a way, they're sort of similar to this idea of someone newly diagnosed. There's 2 ways of thinking about it, and we do not have agreement in the United States. One way is to say, let's start everybody on something that has maybe less efficacy, so less strong, but a greater safety track record. Because we don't know if that person's MS is going to be good or bad, so let's try to take less risk now. The other way of thinking is that MS is a disease that affects your central nervous system, and we know that time is brain, and so what we want to do is we want to take action fast. And so let's start everybody with the highest or the strongest medicine, and then we can come and pull back afterwards. And we don't have an agreement right now in the United States about which way is right, which way is not. What's interesting to me is these discussions are happening among doctors and healthcare professionals. I'm not aware at all that we're having this kind of conversation of doctor community and patient community together to say, are we going in the right direction in the United States? And I think we need to see more of this. We need to see more of this discussion going on as groups and saying, overall for people, should we be taking perhaps greater risk in terms of the drugs, but we're also going to benefit the MS better? Or should we take less risk in terms of the drugs, but we might be taking a risk that the MS creeps up behind us? Second part of the question was about what do we do in terms of when do people come off of medicines, or can they come off of medicines? We don't yet know who can come off of medicine. We don't know when the right time is. There's no artificial date that we can say, oh, well, a person turns this age, and that means that medicine is no longer right for them. And so because of that, there are some clinical trials now looking at people who are reaching a certain age and then also not having any activity, any MS activity for a while beforehand. And so if someone several years hasn't had any activity and they've reached a certain age, the question is, can you try to pull back? Now, the benefits of this is that we don't have to be exposing someone to a medicine they don't need to be exposed to. There's also cost savings. There's other kinds of things. The risks are that a person may be doing so well partially because they're on those disease-modifying therapies. And now you're going to take away the thing that's making them feel so well. And every time someone has an attack, there's a risk that there could be future problems. And so those are the kinds of things we're trying to weigh. There's a lot of pressure going on from the government and from insurance companies, obviously, to stop therapy. But I think we have to stay strong in the MS community and say, until we have better understanding about who the right person is to pull away, we have all, as clinicians, seen people who look like they were doing well. We took them off therapy, and then they had a devastating relapse or a devastating attack or devastating progression of disability. Why did we do that? And so those are the things that we're thinking about, and that's why it's actually being studied in randomized controlled trials at this time.
Next question. We got one over here.
Thank you for being here, Doctor. My question is, what are the options for people that cannot have MRIs in terms of diagnoses and also monitoring progression?
The question was, what are the options for people who, for whatever reason, cannot have an MRI? So MRI is a large magnet, so if you have metal in your body, then that would be the kind of person who cannot have an MRI. What are the options in terms of diagnosis and for following that person? Well, firstly, in terms of diagnosis, MRI is just one little small piece of it. The diagnosis of MS is a clinical diagnosis. It is still based on the idea of separation in time and space. What I mean by that is if you have neurological symptoms that are coming from the central nervous system and they're separated in time and space, that is the hallmark of what multiple sclerosis is. What MRIs did was make it possible to diagnose MS earlier, but they didn't make us diagnose MS. And MRI itself is not what diagnoses MS. It's the incorporation of the MRI information into the clinical history of that person with multiple sclerosis. So the MS diagnosis can certainly happen without MRI. In the United States, we generally use MRIs because they're available and most people can have them, and so it would be hard to tell a person we're not going to do a test that we think could be helpful and could help us understand your diagnosis. And then in terms of following, we use MRI to follow, but a lot of us also use clinical activity to follow. So we say, how are you doing clinically? We check your examination. We may see what new symptoms you're having. There are other things we do besides MRI. So not being able to have an MRI, not great, but it's not a clear disadvantage.
Next question's here.
What is the status of the remyelinating medications, and when would you guess they may be available?
The question was about remyelinating medications. So when we think about MS, we think about it as demyelinating. So myelin is that white matter, that fatty covering to the nerves, and when it gets stripped away, we call that demyelination. The idea of remyelination is, can we turn those things around and now make that myelin form again? There's several medicines that we're looking at. One was a medicine that was talked about more. It was called anti-lingo. The anti-lingo medicine, unfortunately, did not look like overall it worked in terms of remyelinating, in terms of forming new myelin. They're still investigating it. They're still trying to see if there's anything they can understand, because they've invested a lot of time and money, obviously, in studying it. But there are other medicines. So there's medicines like RHIGM22, which is a little bit earlier on, where we're looking at that medicine for in terms of remyelination. And then some of our colleagues are actually looking at large libraries of already generic medicines that are already out there, and saying, which of these medicines have the ability to turn on myelin and to remyelinate, and then that medicine is already available. And so that research is going on as well. And so it will be several years before we see an actual agent that will be there for remyelination, and then it's still not going to replace this idea of disease modification. Because at the same time that you want to make new myelin, you still want to make the body stop attacking itself. So we're still going to need medicines that cause us to protect ourselves from relapses and disability. So we're still going to need medicines that disease modify.
So another question that I have from you from way back here in the room is that on terms of patients and caregivers learning to communicate better with each other, what are they doing now how are the doctors getting there and asking such questions that have nothing to do with medications, but maybe just what they're doing in life and how things are changing, and how clinically their MRIs could be perfect, all right, no changes, they're showing stability, but yet might be some of the gentlemen, they can't get that little button put together on their sleeve, and they need help from somebody else, or just buttoning a regular shirt, or male or females having problem getting the shirt over their shoulders, or stepping out in that backyard and finding that little step that goes out that they can no longer just make that step because they're going to fall, or that they can't get up that little step, or that they're having problems lifting their leg and get into the shower. Now, these are things that patients often do not bring up, during when they go into their medical appointment, because it's not on that list of what's wrong with you, and nor is the clinician knowing to speak about it. And this is something that MS Views and News is going to be doing during the course of the year and next year, to try to bring the physician community and the patient community together on this and try to find out how these questions can be better asked, okay, when a person goes for their medical appointment. Because if you're actually showing these signs that you're having these problems, then you could be still worsening. Yes or no?
The question was about whether, beside what's going on with your MRI and beside the big relapses, could you still have worsening that's going on? And could that manifest itself as things like trouble with buttoning, or trouble with using fine motor skills, or problems with walking, just things that go on slowly? What you've basically described is progression of physical disability. And it's so important to bring those things up to your doctor, because your doctor is not going to know that that's going on unless you tell them. Unless you tell them I'm having more difficulty now than I had before, things like MRI are not going to pick up progression of physical disability. If your doctor is even timing you walking, so if you have a 30-second delay in your walking compared to last time, it may not alarm your doctor that something major has happened. And so what you want to do is you want to let your doctor know that, okay, I haven't had any relapses, any major flare-ups or exacerbations, but I have seen a slow decline in progression of disability. That's going to be very important for your doctor to know. And the way I tell people to help them understand, well, what is a relapse and what's progression of disability is it's not a difference in terms of what the symptom is. It's a difference in terms of the slope or the time course. So if you say, I'm not walking today like I did 5 weeks ago, that is probably an attack or relapse of multiple sclerosis. If you say, I'm not walking today like I did 5 years ago, or I'm not using my fingers today like I did 5 years ago, you are probably describing progression of disability. It creeps up on you. It's slower than what happens in terms of a relapse. It's very important. It may mean a change in disease-modifying therapy, or it may not. Depends on what disease-modifying therapy you're on and what your history is. But it may mean reason for other types of treatments. It may mean reasons for symptomatic treatments. It may mean reason for physical and occupational therapy. It is definitely something that you want to bring up to your neurologist.
Thank you. Question here?
Hi, doctor. Thanks again for coming. Do you get it often where your patients kind of go into, for lack of no better wording, into like a funk where they choose not to take their medications for a period of time because they don't feel it's doing anything for them?
The question was, do I see people who get into a funk and stop taking their disease-modifying therapies because they're not sure it's helping them? Well, there's really two things going on there. One is whether people get into a funk and are actually having signs of depression that aren't being taken care of. So a person is in a way giving up on what's going on with them. The second part of that question is whether a person stops taking a medicine because they feel like it's not helping them. Well, if that's the case, then what they should be doing is talking to their neurologist about finding something that they do think will help them. They should be letting their neurologist know that I don't feel like this is necessarily the right medicine for me. But the corollary of that is not to then just reject disease-modifying therapies in general. It might be a reason to switch what you're on, but not to reject in general. If you're rejecting in general and you're not doing things that you love doing, and you're not taking enjoyment out of life, that's times when you should either look at yourself and realize that you're going through depression, or if you see people around you that are in that situation, you should realize that those may be signs of depression, and there is help available. There's not just help with medicines, there's not just antidepressants, there's a lot that can be done with talk therapy. And for people who don't want to go to a separate mental health counselor, there's also pastoral care, where you can go to your place of worship and you can talk to your pastor, and that can possibly help with those signs of depression as well.
Insurance. Many people, their insurance companies are denying the medicines that the doctors have put them on. So what kind of information do they need to put together to verify so the insurance company will put them on medicine?
The question was about insurances denying therapy chosen by doctors. As I think we've all come to learn, because there's really three people in the office visit, right? There's the doctor, there's the patient or the person with MS, and then there's the payer. So there's the insurance company. That insurance company is going to have a big sway on what goes on. And what that means is that there has to be good documentation about why a decision is being made for a particular medicine or not. If it's not on what's called the formulary, so the list of medicines that's approved by the insurance, there has to be a reason why you can't be on the other options. Sometimes we do have to put people on medicines that the insurance company wants them to be on, even though that may not be the first medicine we would have chosen, because the insurance company is the one paying for it. There are some bills right now in Florida and in many states in the Senate and in the House looking at these issues of, can an insurance company make you fail something before going on the medicine your doctor wants you to do? In the meantime, before the appeals happen, should they allow you to be on that medicine while all the process of all the bureaucracy is happening? Those things are stalling in different state capitals, including in our state capital. And those things are constantly going on. It's really hard actually to keep up on in terms of what's going on. You sometimes can talk to your doctor or talk to other nonprofits about how to follow what's going on and then what to do about it. How do you call your legislator? How do you contact your legislator? If you don't live too far away from your state capital, what can you do to actually go there, which is better than any of the other things? Can you see your legislator when they come back to their district? Talk to them. Let them understand you as real people. There are discussions right now going on in our state capital that show that the people who are talking about it are disconnected from actual people with diagnoses. They think they're solving the problem by saying that insurances can't make you fail something you've already failed. I don't actually know an insurance company that makes you fail something you've already failed. So we're solving something that's not a problem instead of actually solving the real problem. And that's where it is a long road, but it's a road that we have to work on together, and that's the doctor community, the healthcare community, as well as the patient community together.
Thank you. Any other questions? If not, let's give Dr. Kantor a round of applause. Thank you.
Great. Well, thank you so much.
Thank you, thank you. Thanks for coming down here today. Great. Listen, we want to thank you all again for coming today. And again, I want to thank Sanofi-Genzyme, Biogen, and Mallinckrodt for giving us the sponsorships to do today's program. Thank you for coming.